An emergency symptomatic irreversible pulpitis, tooth number 30, lower right 6. I'm Bill Nudera. Stick around, watch how I manage this case. Welcome to my channel dedicated to clinical endodontic education. This patient presented to me on emergency following crown preparation on tooth number 30, lower right 6, with a symptomatic irreversible pulpitis and symptomatic apical periodontitis. The preoperative periapical radiograph shows tooth number 30 with a provisional restoration placed about 2 weeks prior, and there's no signs of caries, no signs of any periapical pathology. This was a long-time patient of mine. I've seen this patient several times throughout the years. I also treated tooth number 29, the lower right 5, in 2010, and tooth number 31, the lower right 7, in 2011. It's really nice to see some of these long-term follow-ups. Both those teeth are asymptomatic with no signs of any pathology. The CBCT scan confirms the absence of any periapical pathology on the tooth of interest today, and it really shows that I'm dealing with 3 canals, 2 in the mesial and 1 broad canal in the distal. And while I have that scan open, we can also see that those teeth that I treated about 10 and 11 years ago remain stable. The intraoral evaluation shows no signs of swelling or infection, and there were no significant probing depths. This is a really nice provisional crown, by the way. Following profound anesthesia, I always like to test my anesthetic before I get started, especially in cases with symptomatic irreversible pulpitis. So I'll take a little refrigerant spray on a locking cotton forceps and spray a cotton pellet and test it at least 3 times. In order for me to move forward with treatment and ensure that everybody's going to be comfortable with the treatment, I'm looking for 3 no responses with that refrigerant spray to confirm profound anesthesia. I used a split dam technique with rubber dam blockout material for aseptic control. The dentist I'm working with here typically uses more of a semi-permanent sort of temporary cement in order to place their provisionals. So removing this provisional really wasn't much of an option for me, so I treated it just like it would be a full coverage restoration and made my access through the provisional. Now, as a standard protocol for most symptomatic irreversible pulpitises that I deal with, even though we've tested for profound anesthesia, it always makes me a bit more comfortable to supplement the anesthesia with an intrapulpal injection. Now, the vast majority of the time, this is just a formality, but occasionally, even though you've tested it and got that profound anesthesia, there is that slight possibility that the inflammation that's created the issue could create a problem with anesthesia. So I'd like to take care of that all right at the beginning and just add a little supplemental anesthesia through the interpulpal injection technique. So I go ahead and go through all of my protocols: canal negotiation, shaping, irrigation. I dry the canals, and then I move to the obturation. I chose a single cone obturation techniques, so I injected the canals to approximately the mid-root with some BC sealer, and then I'll take a paper point, measure the length, and plunge it through the sealer. I then reapply sealer in the same fashion I did prior, take a pre-measured gutta-percha cone, placing it through the sealer to length in all canals. This is my cone fit radiograph, confirming the cone placements are accurate, and I'm going to go ahead and move forward and complete this case. I sear the gutta-percha off at the levels of the orifice, place a bonded orifice barrier, and I close the tooth with a sponge and cap it. This is the final result, some really nice conservative shapes with this case. And it's always interesting to me to compare and contrast my treatments over the years to see how my philosophy's changed and evolved. We can see in the other teeth next door that the canal preparations are quite a bit larger than the one that I perform today. So having an evolution of your treatment philosophy is very normal over the lifetime of a practice. And who knows, 10 years from now, it may be completely different. Well, I hope you've enjoyed this video presentation of mine today. Don't forget to hit that subscribe button so you can stay up to date with all my new videos. I'm Bill Nudera. Thanks for watching.